you're giving me a little counter there, shot? Yeah, no, that's fine. Shot. All right, give me an AP, quick. Quick AP. Stay there. All right, too far to my side. Shot. Now, looks better. Go back to a lateral. Quickly. All right, 2, 3, 4, 5. Shot. Shot. Give me an AP now. Quickly. My hand is really getting uncomfortable. Looks good. Coker. Stay there. Don't take a shot. Don't take a shot yet. All right, shot. That's good. Lateral. So this patient has 2 herniated discs, C5-6, C6-7, and she's having beautiful arm symptoms in both. Right is greater than left. And where's the AP again? You still have that up, right? Nice job. Perfect. Looks great. We're inside the disc space. And that is, you can count the vertebrae from the top. I could see C2, then 3, then 4, 5, 6, 7. I believe we're at C6-7 based on the X-ray image. Everybody else in agreement here? 2, 3, 4, 5, 6, 7. It's always good to count more than once, at least twice, maybe 3 times, just to be 100% sure. We're doing the C6-7 and C5-6 disc herniations today. So she has 2 disc herniations that are causing her symptoms, number 5, 6, and 6, 7. Did you pull? Is that a pull? All right, so we're going to do a discogram right now. Shot. And shot. Let's get a pull. There we go. That looks good. I would love to get a little more of the X-ray south. Move it south about 1 inch. Maybe not even 1 inch. Wait. And let's get these shoulders here, Luis, on the side quickly. And give me a shot. That looks good. That looks good. All right, so the dye is leaking out through a tear in the back of the disc. 2, 3, 4, 5, 6, 7. And we're done with your services. Yeah, you don't have to hold her head anymore. All right. Yeah. Let me have the guide wire. So at this point, our needle is in excellent position on the AP and lateral views. Shot. And now I'm going to bring our guide wire down through the needle. And we are at C6-7. We've confirmed that with the X-ray. I'm going to remove the needle. How's our blood pressure? It's good. Perfect. I like it. Shot. Did you take a shot? That's it? That's your shot? All right. So you can see the needle is coming out. The guide wire is staying in the disc space. I'll do a little, so let me show you where we are right now in the case. I'll take a step back. This patient has neck pain. She's getting headaches from her neck going up the back of her head. She has chronic neck pain, and she has pain that radiates from her neck down into her arms, worse on the right side, okay? I think she has some weakness as well. So she has what's called a radiculopathy, which is issue with the nerves coming out of the spine, off the spinal cord, out the holes called neuroforamen, right behind the discs. And specifically, if she has a C5-6 disc herniation, it's going to be the C6 nerve root. And a C6-7 disc herniation will be the C7 nerve root. So right now, we had half a drop of blood for the whole surgery. I'm going to inject some local before we make our incision. It has epinephrine, so it will stop any bleeding from the little capillaries and arterioles just below the surface. We injected half a cc of Marcaine and lidocaine and epinephrine combination. Give it a minute to work. So while it's working on vasoconstriction, I'm going to just talk for a minute. So she has 2 herniated discs that are symptomatic. They're herniations. One of them is a bulge. Bulge is a small herniation, somewhat contained by the posterior longitudinal ligament. So a contained herniation means a disc herniation that is contained by the posterior longitudinal ligament, which is right behind the disc. It doesn't mean it's contained by the annulus. So to have a herniation, the annulus, which holds the jelly inside a disc, rips through trauma, either sports injury or some other type of traumatic injury, car accident, work injury, just jumping off the roof of your house into your pool when you're a kid. I mean, a lot of people don't know what they did, but they do things. Gymnastics, golf, all those things can cause trauma to the annulus. The annulus is a membrane wrapping around the disc on the outside. It's thick, it's elastic, it's tough, and it holds the jelly in the center. And that membrane rips from trauma, and then the jelly pushes out through the rip under pressure, because the jelly gets pressurized whenever you move, whenever you flex, extend your neck or your back, and whenever you carry something. All that weight you carry is transmitted to your spine. It causes your bones to collapse on each other. It puts pressure on the jelly, and the jelly pushes out through the tear. So that's what a herniation is. And a contained herniation is one that hasn't gone through the posterior longitudinal ligament. Therefore, it's not directly on the dura or covering of the nerve roots. But there could be a tear in the posterior ligament, and it could be to the side of the posterior ligament, and that's when it starts irritating the nerves in the dura, causing headaches and radicular symptoms. So we are going in to perform the Duke laser disc repair. It's an endoscopic spine surgery technique, and the primary goal here is to debride the annular tear so that it will heal. We're also going to remove the jelly that's stuck between the annular tear. It's called the interposed nucleus or herniation, and anything that is in the foramen or epidural space we'll remove as well to get any pressure and irritation off the nerve roots and spinal cord. Okay? So her worst arm is right. That's why we go on the left side of the neck. Incision. We're going to make a 4 millimeter incision. You don't go deep. This is superficial. Okay? That's it. The whole surgery is going to be done through this incision right here. You see that? This is really the most minimally invasive, best spine surgery in the world to fix a herniated disc. But unfortunately, not many surgeons know how to do it. So we're broadcasting it so people can learn. All right, little shoulder pull, just gentle shot. All right, perfect. So I'm going to advance this dilator down to the spine, and I'm twisting it as I'm advancing it. Shot. And I've anchored the guide wire right onto the end plate of C7, so it's not going anywhere. And I'm right in the front of the spine right now. Shot. Yeah. So I want to get an AP. So we looked at the lateral view. I'm at the front of the spine at C6, 7, 2, 3, 4, 5, 6, 7. And then we're going to get a AP view to see where we are. My goal is to be very close to the midline, as close to midline as possible. That's perfect. So you can see the spinous processes, and we're pretty much got a nice AP view. The spinous processes are located directly between the cervical facets and pedicles, and our tip of our dilator is literally right just to the patient's left of the midline, which is really, really good. So on the sides of the spine, take this, there are muscles called the longus colli muscles. They run up and down the front of the spine, and I'm between them. There's a little gap between them where there's just anterior longitudinal ligament, or ALL, as we call it. Now I'm going to push this through the ALL shot just to get it seated, and then we're going to get the guide wire out shot. Give me a little shoulder. That's beautiful, guys. All right, Sean. So we're going into C6-7 with our dilator shot. I want to get to the back of the disc where the herniation is, Sean. And I'm using a little bit of her soft tissue play, like the tissues, you can mobilize them a little bit with the dilator to get the right angle to enter the disc space. You want to enter the disc space at about the angle of the disc space. If you're too oblique to the disc space, then you're going to end up not being able to get to the back of the disc space. So here is the whole surgery is done endoscopically through, and this is the Duke laser disc repair surgery that I invented here, created here at Duke Spine Institute. It's a variation of endoscopic spine surgery. And what makes my surgery unique, and we've already been published the surgery, it's been peer reviewed and published multiple times. What makes the Duke laser disc repair surgery a little unique is that I'm not just removing a herniation, okay? I'm actually spending most of the surgery, the majority, about 95% of it, debriding the annular tear. And this is the first surgery of its kind in the world that debrides the annular tear. Other surgeries don't debride the annular tear, but this one does, and I use a laser to do it. So we'll see that during the surgery, okay? You'll see some chunks of disc coming out, and you'll see me debriding the annulus, and I'll tell you as I'm doing it. So right now I'm advancing the tubular retractor down over the dilator, and I'm going to remove the dilator once the tube is in position. Can you squeeze my mask around my nose a little bit? It's tickling me on that side. Yeah, for some reason there's some buzz or something in there. I think that's better. These masks. Give me a second. It's still tickling me. There's like a fuzz or something just rubbing against my nose. Come in through the side. Yeah, and just kind of go in there and try to grab it out if you can. I don't know what it is. It's just like you know how the masks get that fuzz? Let me feel. Yeah, that's good. That's good. Thanks. All right. So, folks, just in case you weren't aware, this whole surgery is done, sterile, prep and drape, just like any other spine surgery. We have a sterile field. We use this Ioband, which is the plastic, and the DuraPrep, which contains iodine. We've lost less than a drop of blood, and we're going to lose less than a drop of blood the whole surgery. So endoscopic spine surgery, like the Duke laser disc repair, has minimal blood loss. I got to advance the tube. That's what I'm going to do next. So every other surgeon in the world, basically, that doesn't know how to do endoscopic surgery like this, which is about 99.99999% of spine surgeons, they don't know how to do the surgery. They're going to be opening this neck up and taking those discs out completely. And we're avoiding that because this patient doesn't want that done. You don't need to take the discs out to fix the part in the back that's damaged. Shot? So if you do endoscopic spine surgery like we're doing, we pass through the normal disc. That's what you're witnessing right now. We're going through the normal disc. Shot? Okay, we're going through the normal disc, which is inert. It's biologically, essentially inert. It's not 100% inert, shot, but it's pretty darn close. It doesn't have much metabolic activity. It's got just it's just a jelly, like a compression jelly, a hydrostatic compression jelly. That's what the disc really is. So it's not like we're damaging it in any way. We're just passing through it. So I was not the first person to do transdiscal endoscopic surgery. I learned this from the South Koreans and a German surgeon and a British surgeon and an American surgeon. So I had several teachers. And the approach of getting here is not my approach. It's one that I've learned from other surgeons who do this type of surgery. But the transdiscal cervical surgery was really pioneered by the Koreans, South Koreans. And they're the ones who taught me. Specifically a surgeon named Dr. Sang-Ho Lee. He probably doesn't even remember me. He's kind of a big shot over in Korea. But long story short, there are probably a lot of surgeons that have trained with him, but he taught me the approach, what we've seen so far, okay? Now, the difference, the Koreans were doing these surgeries with the patients, yeah, you can relax, with the patients being awake. And the problem was the patients move around when they're awake. So they had a few patients who were paralyzed as a result of their technique. Plus, they don't use the laser like I do. They use a different laser. I chose this particular laser for the reasons that it provides the best results. So I tried different lasers, and I tried theirs, but this is the very best results. And they don't do an annular debridement like I do. So pull the fluoro back a little bit. I'm just going to show our audience so they can see. Can you all see this here?
Yes, we
Sean?
can.
So everything is being done through a tubular retractor. This is not a percutaneous surgery. Percutaneous things are done with needles. This is not a needle. And it's just a very small incision, the smallest incision in the world for spine surgery. And it's a 4 millimeter incision. So it's about quarter of the width of a dime, a United States dime. Very small. And I've done over 1,300 of these surgeries endoscopically now. We've had 0 complications to date. Not a single patient has ever had a complication. The only problem is that some patients do get recurrent disc herniations where another herniation will happen where I did the surgery. It's about 1% of the patients, 1 in 100 chance. And most of the time it's because they're lifting or doing something they're not supposed to do, but sometimes they just wake up with it, you know, and we do have people in a collar so that it restricts their movements, but even with the best prevention, sometimes it does happen. So 1 in 100 chance of a recurrent disc herniation, but 0 complications today. Recurrent disc herniation is not a complication. Complications are things that we don't expect or want to happen, but can happen. And this is a very safe surgery. So if you actually read about it in the United States National Library of Medicine, where it's indexed and published in a journal, it's a very safe and effective surgery. This is the disc herniation right here. We're at the base. There's a piece of it. Gonna fish it out. And I'm just gonna keep doing this. I'm gonna go back and forth between lasering to release the herniation fragments. They're stuck down from inflammation. I'm just gonna go kind of in and out, debriding. There's a herniation right there. You see that? You all see that piece right there? Pretty cool, huh? And the herniation rarely ever comes out as one big piece, you know? It's kind of like if you go fishing, you know, you go fishing and you expect to get a tuna, a giant tuna. It just doesn't happen all the time. So, stand by. You know, you go fishing, most of the time you're going to catch some other fish, little fish, but sometimes you get lucky and get the big one. And that's how it is with these herniations. They're mostly in pieces, many pieces. And what that really is, folks, is it kind of tells you about the pathophysiology of herniated discs. And really, I'm the only one that gets to see it directly, except for the people who do endoscopic surgery, which is very rare for that to happen. But you can see that their fragments of herniation are multiple fragments. And the reason they're multiple is because the disease of degenerative disc disease, herniated discs, it's progressive and it's episodic. And so you'll have an incident where you go out and do something and you push out another piece of herniation, okay? And then you get a little fragment that came out. You get flare up of your pain. It's really bad for a few days, and then it kind of settles down a little bit, right? So every time you get a flare up, think about it as another little piece of herniation going out that hole that's already there that hasn't healed. So Duke Spine Institute and myself, we are the ones who discovered this pathophysiology. There's nobody else that's ever described it or talked about or discovered it, because surgeons normally can't see this stuff because they don't have a scope sitting inside the disc. They just kind of scrape it out and use instruments to scrape and pull out pieces. But nobody really understands or has ever described in the past the pathophysiology of disc disease. But we've described it here at Duke Spine Institute, and I'm telling you it's a stepwise progression where you get the injury to the disc and the annulus, and then over time more fragments keep coming out, piling up. They get more and more of a pile. It gets a bigger pile of herniation out there, which then starts causing more and more symptoms. So that's why people may start with a small injury, a little bit of pain, and then over time it gets worse in a stepwise fashion. There's something else in the spine that does the same thing, and that is fractures, insufficiency fractures, okay? So spine surgeons are very familiar with insufficiency fractures of the vertebrae. That's where your vertebral body collapses because of osteoporosis in a patient, and basically what happens is the fracture occurs in a progressive manner, a stepwise progressive manner. So you get the initial fracture, and then it somewhat heals a little bit, but then the patient fractures again, and it fractures a little more. And then there's inflammation and pain as a result, and then it subsides, and then they do something like bending over and it fractures again. And so, you know, most insufficiency fractures, spine surgeons understand the concept of progressive stepwise failure of structural integrity. And that's what's happening in degenerative disc disease, okay? It is a fracture of the annulus that starts with. That's a fragment of disc herniation right there. See how smooth it is? It's been smoothed over by chronic inflammation by your body, by her body, okay? So we found a big tear. These are all pieces of herniation that are coming out. I'm just releasing them because they're stuck down, because they cause inflammation. The herniated fragments of nucleus stimulate the inflammatory response. It's not my discovery that nucleus pulposus is pro-inflammatory. That was proven in lab experiments that were done years and years ago, that pieces of the disc herniation cause inflammation, strong inflammation. That's not my discovery, but I use that knowledge and build upon it with this endoscopic surgery that I do. So I'm removing those pieces from the disc, from the epidural space, back here in the back of this disc, and I'm removing them because they cause inflammation. And the inflammation is why this patient has her symptoms, primarily. That's the primary cause of her symptoms. Inflammation, chronic inflammation. And most surgeons don't understand that. They have no clue about that. They think herniated discs cause compression, pushing on something, squeezing nerves. And that's how they cause all their symptoms. But that is not the case at all. Herniated disc, in my experience at Duke Spine Institute, we've discovered that 95% of symptomatic herniated disc cause symptoms not from compression, but from chemical irritation of the dura and the nerve roots. Chemical irritation. And the unfortunate thing is that there's the herniation, by the way. That's all herniation right there. And that's end plate. See? That's the C7 end plate, that golden thing, and that other golden thing is C6. And I am at the back of the disc. I'm at the right foramen at C6-7, and I am zapping away the herniation out here. It's sitting on the nerve root. You see that? And when I'm done, that will be gone. It's a good size herniation. right there. I'm just getting rid of it little by little, piece by piece. Now, will I need to fuse her? Nope, not at all. Why? Because fusion only is necessary when you take the whole disc out. So it's actually the surgeon that causes the need for your fusions or artificial discs. If the surgeon did what I'm doing, there would be no need for fusion or artificial disc, because we are not removing the disc, the normal disc. We're only taking the herniation out. Okay? Important distinction. The Duke laser disc repair is the only surgery, along with the Koreans' endoscopic stuff, and anyone else that does the transdiscal endoscopic approach like this, where you don't need to fuse and you don't need to take all the disc out to fix the problem in the back of the disc. So could I do a fusion if I wanted to endoscopically? The answer is 100% yes. Why don't I? Because it's unnecessary. People don't need fusions. 99% of herniated discs in the spine have been treated in the past with removing bone to get there, removing ligaments, damaging the spine, and making it unstable to fix the herniation, pain, pressure on the nerves. But with this surgery, we're not unstabilizing the spine with the surgery like every other surgeon does during an ACDF or an artificial disc. Now, if I did fusion, I could make a lot more money. But it's not right to do something that's not necessary for a patient, that is not going to benefit the patient. You understand? And that's unfortunately one of the problems we have in healthcare today, is that surgeons don't understand that concept. They feel that they don't need to benefit the patient. They need to do what they were told to do, how they were told to do it during their residencies, without actually thinking about what it is they're doing. And, you know, bill the insurance companies, basically do what the insurance companies want them to do, which the insurance companies, folks, are not your friend. They do not want what's best for the patient. They want what's least expensive for them. That's how they operate, okay? And I have yet to see an insurance company be responsible about taking care of the patient properly. So unfortunately, we have a system in spine surgery in the United States where vast majority of spine surgeons, they're just taught to do fusions during their training or artificial discs, and they're never really exposed to endoscopic spine surgery like you're seeing here. And that's why we broadcast, is so surgeons can learn more about this technique, more about this technology, so they can give it to their patients wherever they are around the world. That's our goal, is to disseminate this knowledge. Well, we're almost done with this disc. And if you pull the tube back, you're just going to get endless amounts of disc material, which we're not interested in taking the whole disc out, okay? We're literally removing about 5% of the natural disc with this surgery. And I'm almost done, by the way, with this disc. I still have the other disc to do. But I'm at the opposite foramen right now. I'm now on her left side, which is my side. I'm looking at the foramen here, and can see the uncovertebral joint. And it's amazing, the view, huh? It's quite a good view. It's quite a good view. I'm looking at the foramen there, and it's looking pretty good. I'm not really seeing anything substantial. This is the middle of the disc. Those are the end plates there. A little bit of bone spur, but that's not doing anything. That's actually, looks to me like it could be dura down there. Dura of the spinal cord. Just want to make sure we get out everything we need to get out so this disc will heal properly. Remember, I'm not healing the disc. I am merely helping the patient's disc heal itself, if that makes sense. This disc wants to heal properly on its own, but it just can't because that jelly was wedged in there, the blue jelly. And it's blue because I stained it blue with my own stain. Okay, the body doesn't come that way.
We have a couple questions.
All right, we'll take the questions.
One of our viewers on Periscope is wondering, are you worried about scar tissue forming following the disc repair? Great
question. Do I worry about scar tissue forming following the disc repair? The answer is no. There's no scar tissue formation. The skin will have a scar, a little scar, tiny, 4 millimeter. That has nothing to do with the spine. But back here, where I'm repairing the disc, I want you know what scar tissue is, folks? Scar tissue is collagen. And collagen and elastin are what make up this annulus back here. Remember I told you there's a membrane back here? That membrane is made up of collagen or scar tissue. So yes, we want the annulus to heal itself with collagen, but there's no other scar tissue because we're not removing the disc. Remember, we're leaving the disc there. Let's go back the other way. We are not creating scar tissue, and this surgery is so small and minimally invasive, there is no scar tissue formation. Now back here where you're seeing this area right here will form a collagen, but collagen is what's already there. So it's just going to repair itself with collagen, which is scar tissue. Does that make sense? Whereas with other surgeries that are open, you get a lot of scar tissue formation because there's a lot of collateral damage to the tissues by the surgeon during the surgery. Here we have a very small incision and virtually no damage to any of the tissues. All right, so I've gone down into the frame and I've opened it. There's no more herniation in there that I can see. It looks good. The center looks good. I think she's going to be very happy with these results. And let me go back to the other side one more time just to look. Sometimes a little herniation will sneak out when you're on the opposite side, so always go back and look a couple of times. You don't want to leave something in there. All right, I don't see anything really. You have another question?
Yes, we do.
All right, I'll take it.
One of our viewers on Facebook is wondering, does the nucleus leaking cause vertebral modic type changes? And can end plates be causing problems as well?
Oh, that was a good question. So I'm going to try to, I didn't hear it as well as I would like to have heard it, but let me see if I can repeat it. So one of the viewers, I believe, is asking, does the nucleus leaking cause the vertebral modic changes, which are end plate changes and inside the vertebral body, like edema? And I didn't get the second part of the question, but to answer your question, that's a great question. I've never really thought about it, but I believe it's correct because the modic changes are inflammatory changes of the end plate, the end plate being over here. So what's causing those inflammatory changes? Yes, I agree. I think it is inflammation from the tear and the nucleus causing inflammation. Yes, that makes sense. All right, we're done with this disc. It's beautiful. Scope off. We're going to move to the next, C5-6. I believe that's correct. Now, I don't remember the second part of the question. Give me a second, Luis. I don't want to bend that cable. All right. Dilator. What was the second half of the question?
The second half is, can the end plates cause problems?
Can the end plates cause problems?
Yes.
No, the end plates don't cause problems. The end plates are the vertebral bodies are not any problem here. You can get bone spurs off the end plates growing, but they grow so slowly, and honestly, they don't cause inflammation. Bone spurs generally in the spine don't cause inflammation. They may be the result of inflammation, but I don't believe they're the cause of inflammation. Great question. All right, so here's what I'm going to do. We're going to get our fluoro back in. Just leave those. And we're going to, I always start with the lower disc, like C6, 7, because it's harder to get to. And I think getting up to 5, 6 will be a little bit easier. But I'm going to basically put my dilator back in, take my tubular retractor out, and I'm going to march up the spine, the front of the spine. And this is probably the hardest part of the surgery to do this. And do not try this at all without first being trained properly by me. So if you're a surgeon wanting to do these surgeries, do not do this without my supervision and training. You need that. You can't just do this on your own. This is not that kind of surgery. All right, shot. All right, good. Looks good. I'm going to take the tubular retractor out. There are some crazy surgeons out there that will do anything for the wrong reasons. And I am not going to facilitate that. I had to be trained, and this is not a type of surgery you can just wing it. You can hurt somebody badly. All right, beautiful. So you can see we've lost half of a drop of blood. All right, and there are about 20 drops in a cc. So we've lost 1/20th, maybe 1/40th of a cc of blood. There's no blood loss with this surgery, folks. Open surgery, my God, the surgeons, bleed and they bleed the patient, but not with the endoscopic surgery. So blood loss is wonderful. It's minimal. All right, I'm going to go ahead and come out and march along the ALL. Get ready for a shot. Shot. I'm out. I need an AP now. So as you do this, you have to go AP lateral alternating to make sure on the AP you are dead center. You do not want to come off the center of the spine. Basically, I'm running right up the ALL, the anterior longitudinal ligament. Wait. Shot. All right, it's good. Lateral. So I'm in the center. You got to make sure your x-ray is centered too. You can't just assume that the spinous process is centered. You got to make sure it's centered. All right, so we got to get up that little osteophyte. That's a bone spur. Shot. Should be done. Oops, slip back down. Shot. I need an AP. I'm getting close to where I need to be, but I feel like I'm off to the side a little bit. Quick shot. All right, back to a lateral view. By the way, the amount of radiation used for these surgeries compared to regular spine surgery is a fraction. Maybe 10%. Shot. Should be there. Okay, AP. Quick AP. So I'm on the disc. This is 5, 6, 2, 3, 4, 5, 6. And I just want to make sure I'm in the middle. Shot. That's perfect. Back to a lateral. Now, if you don't do this right, it could be devastating. And I mean devastating. And this is the part that other neurosurgeons cringe. I mean, they just don't understand how this is possible, unfortunately for them, because it really prevents them from being able to help their patients better. I need an AP. I feel like I just want to make sure we're on track. So you got to always check AP lateral, AP lateral, AP lateral. We're still in the center. Go, lateral. As you advance things, you always want to be on a lateral view. You don't want to be on an AP view. You can't tell your depth based on an AP view. And the depth is everything. All right, so we're good. We're going down the disc now. This disc is a lot more degenerated than the 6-7. It's a lot, I can feel it. It's scarred down from chronic inflammation. It's stuck together. The bones are not opening and distracting easily. So there's a lot more scarring, actually, of this disc. Sean? Let's get an AP view. Yeah, I'll pull it back. We'll do a discogram, but I just want to see where we are. Sean? Yeah, it's nice. Look at that disc is opened up a bit. You see the smiley face in white? All right, lateral. So we've actually distracted the bones, the vertebrae open a little bit. And I want to come back to do our discogram shot. Yeah, that's good. In case we have any material like nuclear material inside this tiny little hole, we want to pipe clean it. Shot. That's good. So we'll inject our blue dye and our contrast material, our ISOView. Shot. Beautiful. There's the dye. Again, this disc 5-6 is more degenerated. No, I'm not ready for that. I have to advance this first. It's more collapsed, degenerated than the other one. Shot. Then 6-7. Shot. Anybody know what the most common disc to degenerate or injure with herniation and become symptomatic is? No, cervical spine. It's C5-6. It's this one. It's the most common disc herniation to cause symptoms that need treatment, like surgery. All right. Watch the laser fiber. I'm going to advance this tube. This will be our last disc we're doing on this patient. She's very stable. She's doing good, right?
Yep.
You can let her blood pressure come up a little bit if you want. Start to normalize a little more. Shot. Yeah, and you want to make sure you're not advancing your dilator. You only want to advance the tubular retractor. If the dilator keeps going, it's going to be bad. So she does have an osteophyte there, which is big, and we're not going to do anything about it. That's not causing her problem. Shot. Osteophytes never cause neck pain. Shot. And they never cause radiculopathy. And they never cause the headaches that these patients with herniated disc get. Osteophytes are just kind of like something there, but not they don't cause symptoms. Shot. Rarely, I'd say less than 5% do they cause symptoms. Shot. All right, that's about as good as we're going to get it safely. She's still really relaxed, right? I got to make sure she's not clamping up, because that's going to make my job hard. You don't have to unless she... How many twitches do you think she has? I'm not really feeling a whole lot, but it is tighter. But I don't want to prolong her recovery. So let's... I wouldn't do too much if you do any at all. Yeah. Yeah, that's perfect. Shot? All right. Yeah. Shot? moving a little bit, trying to get the dilator out without removing the tubular retractor. Shot? May need the vice grip. Let's try this, just maybe. Never mind, we got it. Little elbow grease. And you all thought spine surgery was delicate. Huh? Right? You know, for neurosurgeons, spine surgery represents the most vigorous type of surgery we do. Everything else is just delicate, micro stuff. But spine surgery, it brings us as close as we get to an orthopedic surgeon. Of course, their carpal tunnel surgeries get them as close to as a neurosurgeon. Carpal tunnel and ulnar nerve. And maybe a little microdiscectomy. My gosh, Luis. All right. So we're getting ready to do the second disc, C5-6. It is degenerated. People ask me, does the Duke laser disc repair work on degenerated discs? Yes, it does. It really does. There it is in the back. Beautiful. So I had something I wanted to say. Are we ready? Huh? There's a piece of herniation. And what we're going to have in this disc compared to the last one had a lot of scar tissue, a lot of modic change to the end plate kind of stuff, but this is going to have more. And look at that golden color on the herniation. That is calcification. So this is dystrophic calcification. That's what happens when the laser, this is a specific type of laser and a specific type of laser energy, but that's what happens when it interacts with calcium. It turns golden. There's a herniation right there. I mean, we're going to get it out. Right now, these bones don't want to move much at all. They're like just locked in from this patient's degenerative disc disease has kind of locked them in. They don't want to move, but we're going to get them moving. That's one of the things the laser surgery does. That's a benefit. Honestly, there's no disadvantage of this Duke laser disc repair surgery over open spine surgery, whether it's an anterior cervical discectomy and fusion or a artificial disc. Those surgeries are like literally going to war with a biplane as your air capacity, as your air assets. You're using a prop biplane from like the 1940s. Those are old technology. They're very dangerous. If you're the pilot, you're going to get shot out of the air. The jets, and this is like a stealth bomber. You have no chance of defeating a stealth bomber, period. This is that much better of a surgery on all accounts, okay? So what makes this surgery better? Number one, blood loss, which we're getting a little bit right now. Where is our irrigation? Come on. Yeah. So when you start seeing like little smokestacks, that means your irrigation is getting slow. And basically, you need to switch your bag of irrigation. For those of you who don't know, irrigation is water, basically, an electrolyte solution, like saline, normal saline that we use, or lactated ringers. Either one is fine. And it basically flows around the laser in through the endoscopic tube to remove the debris and to keep all the tissues cool. Because the laser will heat everything up big time. The laser is going to deliver a large amount of energy. I mean, if we're vaporizing tissues, you better believe there's a large amount of energy being delivered, okay? But it's controlled and it's safe. Anyway, so let's look at all the things that are important in spine surgery and compare Duke laser disc repair, what you're watching, endoscopic surgery, versus traditional surgeries. See why this is the most advanced surgery in the world for herniated discs, degenerated discs, anything to do with a spinal disc. So number one, blood loss. We're going to lose 1 drop of blood for the surgery. An ACDF on average will lose 100 milliliters. We're losing 1/20th of a milliliter. So a typical ACDF is going to lose 20 times 100. It's about 2,000 times more blood loss. There are ACDFs, anterior cervical discectomy and fusion, and artificial discs where they lose even more blood than 100 mils. But that's probably about average, okay? Second, radiation exposure. During typical spine surgeries like fusions, you're taking lots and lots of x-ray pictures. And that x-ray is x-ray radiation. And it's going to get on the patient because it's passing through the patient, okay? It's going to get on the staff. They're going to get radiated. And remember, radiation is cumulative, meaning that, there's the PLL fibers, meaning that if you get a little bit today and you get a little more tomorrow and you get a little more the next day, it just keeps adding up. And it has an effect, a cumulative effect. So if you get 2 units today, tomorrow you get 2 units, and the next day you get 2 units, that's 6 units of radiation your body has received. And radiation unfortunately causes lots of problems for the human body. We actually use it to kill cancer. We use it to kill cells, tissues. And it doesn't just kill cancer, it kills normal tissue. So you want to avoid the effects of radiation for spine surgery as much as possible. And the Duke laser disc repair surgery you're watching now has the least amount of radiation exposure of any spine surgery, okay? So keep that in mind. Also, so we got much less blood loss with this surgery versus open ACDFs and artificial discs. You got much less radiation exposure. The recovery time for this surgery is 1 hour. Literally by tomorrow, this patient could go back to work. All right, if you're having a fusion or artificial disc, that's a bone spur, by the way, right there. I'm zapping right there. And mostly to give me better view of the herniation. Not because it's causing symptoms, but because I can't see the top of the herniation, top of the disc space, unless I take it out. So number 3 is recovery. The Duke laser disc repair, this surgery's recovery is one hour. This evening, this patient will be feeling relatively normal. She'll be walking, eating, doing everything normal, except she'll have a little discomfort in her shoulder blades. But the headache she had before surgery will be gone. Her neck pain that she had before surgery will be gone immediately. Her arm symptoms, I expect to be gone immediately. Okay? So the radiculopathy, myelopathy, cervicogenic headaches, and neck pain, all gone right after surgery. So she's going to feel like a new person. That's what happens with everybody, okay? Without fail, as long as the surgery's done right. Okay? As long as I've made the right diagnosis to treat the right discs and the surgery is done properly, the results are they're pretty much immediate, and they're quite amazing. So the recovery is very quick, faster than any other spine surgery in the world that treats herniated discs. I'm not comparing to an epidural, because an epidural is not a real spine surgery. That's just an injection of medicine, okay? I'm talking about surgery. This is disc surgery. We're operating on the disc, okay? Disc surgery is pretty much the standard of care for disc herniations and degenerative disc disease that's symptomatic. So the recovery is pretty much 1 hour, whereas with ACDF and artificial disc, you're looking at months and months of recovery. Okay? Now, what about painkillers? Does this patient take painkillers? The answer is no. They take Tylenol. Tylenol. That's an over-the-counter medicine, acetaminophen. It is very safe for the most part unless you have liver disease. And you don't need narcotics after this surgery. Nobody takes narcotic painkillers. So after ACDF and artificial disc, you're going to be taking narcotic painkillers. You're going to be on drugs, powerful painkillers. You can't drive on them. You can't work on them. You can't fly a plane on them. You can't operate equipment on narcotics. So our patients with this laser endoscopic surgery, go back to work right away because they're not on painkillers, narcotic painkillers. They don't get addicted to painkillers. They just take Tylenol for the surgery. It's remarkable. And then let's talk about results. The Duke laser disc repair surgery has the best results. We have a 98% elimination of neck pain from these herniated discs. 98% elimination of arm symptoms like pain, numbness, tingling, weakness down the arm. All right, there is nothing that compares with fusion and artificial disc. They don't have those results. Okay? And the headaches that people have, about 2/3 of the patients have headaches before surgery from their neck, from their herniated disc. Those headaches go away as well, about 98%. So all the symptoms from the herniated disc improve by 98% on average. Most patients have 100%. How do we know? We ask our patients after surgery. When we see them in clinic or we talk to them on the phone, we ask them, how much pain relief did you get? And the answer is usually 100%. So there is no fusion surgery, artificial disc surgery that gives 100%. Okay, it doesn't happen except for my fusions. But I'd rather do these for people than fusion. Right, Luis? No, that's interesting. There's a tear there in the posterior ligament, a lot of scar tissue. I don't know if you guys can appreciate that. Oh, by the way, moving this thing around is kind of like playing a video game. You have to be good at video games. So if you're interested in working at Duke Spine Institute as a surgeon someday and assisting me in taking care of these patients, start playing some video games. Make sure you got good grades. I only hire smart people. All right. Any questions, Sean?
None others currently.
Huh?
None others currently.
No questions. Great. All right, folks, we're going to wrap this up in about 3 minutes, and then we're going to go to our next patient. And our next patient is a lumbar Duke laser disc repair, 4 levels. Sorry, 3. No, 4. I think it's 2, 3, 3, 4, 4, 5, 5, 1, isn't it? All right, well, whatever it is. It's either 3 or 4 levels. That's the most we can do at one time. That's the foramen. It's looking pretty good. Oh, I see. All right, so if you're interested in watching one of these done for a herniated disc in the lower back, that's next, all right? I am out in the foramen and I'm removing actually a bone spur right here. For those of you wondering, that golden thing is a bone spur. And there's the nerve root just underneath it. See that? So I think this patient's going to do really well once she heals up. I'm taking about 0.5 millimeter of the nerve, of the, not nerve root, the bone spur. And it's really more scar tissue that's calcified out there in the foramen. Beautiful. I'm going to go look at the other direction one more time and we're done. Okay, we'll be done with the surgery. Any questions before we wrap this up?
There are none.
Yes. You have another question, Sean?
No, there are none.
All right, excellent. Well, thank you for watching. I'm Dr. Ara Jukmajian, CEO and founder at the Duke Spine Institute. We are going to be wrapping this surgery up as we're done. This is endoscopic spine surgery. Stick around and see what the incision looks like. It's amazing. It's all done with a 4 millimeter incision. Okay? 4 millimeters, tiny. Not like a big scar that you get from a fusion surgery.
Lights on, please. Go.
This patient is not wanting a fusion. And maybe we'll be lucky enough she'll let us interview her after surgery. We'll see how she's doing. Hopefully she'll be doing well.
Yes, please. Thank you.
Most of our patients allow us to interview them. all of our patients give consent to have the broadcast done, you know, with anonymity. In other words, not knowing their identity and just seeing their neck or back or thoracic. And I appreciate that. We have great patients. This is not the right one. Thank you. All right, I'm going to show you right now. Can you guys see this, Sean?
Yes, we can.
All right, we're coming out with the tube, and I want you to see the incision. This is on the left side of her neck. Everything went beautifully. Couldn't have gone better for her. So because there's no big opening, folks, because there's no big incision, there's no potential space for a hematoma to develop, a blood clot. So even if there was bleeding, it would be contained by the corridor, the surgical corridor, which is only 4 millimeters. Okay? So what that means is you can't get a postoperative hematoma. It's virtually impossible. It could be a retropharyngeal one. Again, very unusual, very rare that it would happen, but it can happen obviously if the blood pressure gets out of control or I hit some artery somehow. But long story short, the seromas that surgeons get after spine surgery, which is a fluid collection under the skin, they don't happen because there's no incision. It's a 4 millimeter incision. That's it. So a lot of the complications that can happen from regular spine surgery, I don't even think surgeons consider seromas to be complications. They happen in virtually every open spine surgery there is. So it's just part of the expected, you know, body's response to the surgery is a seroma. We put drains in when necessary to drain them out for 24 hours or 12 hours. Everybody's a little different, but point is you can't get a seroma with the surgery. That's the beauty of it. There's no post-op seroma, fluid collection. All right, I hope you've enjoyed the surgery. I'm Dr. Ara Duke-Majan, CEO and founder of Duke Spine Institute and the pioneer who pioneered the Duke laser disc repair procedure. Our patient will go home in an hour. So we'll try to visit her again and see how she's doing. All right, let me show the incision. Sorry. Here's the incision, folks. Here's my fingers. Look at the size of that surgical incision. Incredible. Duke Spine Institute, that's where you go if you want the most advanced disc surgery in the world. Sean, if we have any questions from the audience, have them type them up and I'll head over there and be happy to do a quick post-surgical interview and answer questions. So stick around if you want to ask questions. I'll do a quick description of the surgery.
All right, everyone, thank you for joining us for the post-op Q&A. We're about to sit down with Dr. Duke, where he'll tell you a little bit about the surgery you just watched and answer some of your remaining questions. We're going to be switching over to his face cam, and I'll hand the mic over to him now.
Okay, are we working on a attachable mic, Sean? Okay, I'm Dr. Duke Majan, and I just finished up doing this particular surgery you've watched. It's a cervical Duke laser disc repair. It's a name you may not have heard of before for a spine surgery, but that's because it's a very unique type of procedure. And we pioneered this surgery here at Duke Spine Institute about 17 years ago. I've been performing the surgery now for about 17 years. The surgery is all FDA approved, 100% legal, FDA approved, and it is peer reviewed by my peers, neurosurgeons, and published in journals in the National Library of Medicine. So it is an up-and-coming state-of-the-art surgery. The only issue is that most surgeons don't know how to do it. And so they can't offer it to their patients if they don't know how to do the surgery or don't know about the surgery. Unfortunately, I can't be held responsible for the knowledge and education of all the spine surgeons in the country. But you, if you're having spine surgery, you can hold them accountable and ask them why they don't do this type of surgery. I recommend you do. The surgery that most spine surgeons would offer this patient is something called a fusion. And a spinal fusion involves putting a piece of metal holding the spine together. And a lot of times we have to put cages in. I don't know if you can see the little cage there in between the bones, right in there. You all see that? And there's another cage right there, okay? Sorry about the blurriness. I'm looking at my screen to see. So it involves removing the whole disc and putting that plastic spacer in there. And then putting a metal plate on the front. And over time, it takes about 6 months for the bones to fuse together to make a single bone. But basically what you're doing with a fusion surgery is you're restricting the movement of the spine. The spine was meant to move. Can you hold that? Our spines are designed so that we can take our head and we can go look to the side, look up, look down, and then kind of lateral bending. So we call this flexion, extension, rotation, and lateral bending, side to side, okay? When you fuse a spine, you lose the movement, and it's permanent. You can never get it back. So you're always, the rest of your life, going to have stiffness in your back or your neck. The surgery I designed with the Duke laser disc repair was to prevent that stiffness. It was really to preserve motion, natural motion. I'm not talking about putting a metal disc. That's old technology. I would not put a metal disc in my neck or my back. To get one in your lower back, you have to go through the belly. And going through the belly is like walking through a minefield. You never want to have to go through the belly for any spine surgery. It's very dangerous. But surgeons do it because that's all they know how to do. So why would a patient ever want to subject themselves to harm during surgery by a surgeon because your surgeon never learned the right way to do the surgery, okay? That's why we broadcast here from Duke Spine Institute. We want you, the patients, the public, surgeons, we want everyone to know the absolute truth. And the absolute truth is the ways that spine surgery is done today in 2021 and for the last 20 years is basically outdated, outmoded, dangerous, harmful, expensive, and unnecessary. And the person who bears that is the patient, not the surgeon. Surgeons get rewarded for doing outdated, bad surgery. They get rewarded for doing fusion surgery. They get rewarded for doing artificial discs. They get paid. And they get the kudos of the implant companies, the Medtronics and the Sophomore Danik, the DePuys and the Synthes and Nuvasives and Alphatechs out there. They all reward surgeons, okay, for doing fusions and putting metal in patients. People don't need metal anymore in their spines. We can fix the disc problems easily with endoscopic Duke laser disc repair. The problem is these surgeons don't want to learn this new technology. There's an old saying, you can't teach an old dog new tricks. And that's unfortunately pervasive in the spine and neurosurgical and orthopedic world. So, long story short, this patient would not compromise, and I don't blame her. She knew what she wanted. She wanted relief of her neck pain, relief of the headaches, relief of the arm symptoms, but she didn't want a fusion. She didn't want metal, and she didn't want to lose the movement in her neck. She didn't want the big ugly incision. She didn't want difficulty swallowing after surgery like you get with artificial disc and fusion. Not a single Duke laser disc repair patient, endoscopic surgery, has ever had trouble swallowing, ever. And we've never had hoarseness after surgery. We've never had difficulty with painful swallowing, which is called odynophagia. So we've never had difficulty swallowing, odynophagia, and hoarseness after Duke laser disc repair because we're not making a big incision and moving the esophagus over or affecting the nerves to the voice box. Sure, the tube going down will give a little vocal cord irritation for a day or two, but that usually goes away by the next day. So you've watched the most advanced spine surgery in the world, endoscopic, Duke laser disc repair. We fixed 2 herniated discs in this patient. I'm hoping she does very well. The standard is that patients do exceptionally well with their pain. It goes away basically, and I expect her to do just as well. There was a lot of scar tissue in there, especially in the C5-6 disc. Those bones were not moving very much at all. But by the time I got done removing that scar tissue in the back of the disc and getting rid of the herniations back there out of the foramen and the bone spurs, I think there was significantly more movement, probably about 1 or 2 degrees of movement of those bones after the Duke laser disc repair. That's my estimate. Before the surgery, there was no movement at C5-6 at all. So I think she's going to be happy with the results. She'll have some discomfort in her neck for a day or 2 from the surgery. That said, I think long term she's going to do fantastic. So do we have any questions? None. Boy, the audience knows everything these days. Maybe you guys should be teaching me. I should be asking you all questions. Anyway, next surgery will be a lumbar Duke laser disc repair. We'll be doing L2-3, L3-4, L4-5, L5S1 on a patient who has back pain that spans the entire lumbar spine. And this patient has herniated discs along the whole spine. We're going to test each one with a discogram first to see if they're painful before we do the surgery on each one. Okay? See you soon.